this is an overview for the antibiogram and the antibiotic restriction list. So all the hospitals will have their own antimicrobial stewardship program, where it might consist of medical provider, physicians, and also pharmacists, who are expert in antibiotics. So every hospital will have antibiogram and I believe you have kind of gone through antibiogram and know what it is used for from ID course. But just kind of give a brief review. So every hospital will have different susceptibility for each and like microorganisms, bacteria, and also their antibiotics. So this is specifically the antibiograms for case space. As you can see, it's organized by the bacteria, so gram-positive, gram-negative, Candida, and the last tab will be antibiotic resistance restrictions. So gram-positive cocci, there will be a list of gram-positive bacteria here. And sometimes they might have additional isolates being resistant, like for example, VRE vancomycin resistant enterococcus. Again, same thing, just different species, right? Not MDRO means like they're not multi-drug resistant organism, which means like they're pretty susceptible to narrower therapeutic antibiotics. And then MRSA, as you know, is methicillin resistance. So each of this bacteria, are going to have different susceptibility for different antibiotics, and the antibiotic is going to be at your top column right here. Red means like they're super bad. Yellow, they're intermediate, but probably, like you might want to have, recommend something that is green in color. So this is going to be how you use it. So for example, your Staph aureus, not MDR01, Naftalin's 100%, so you can probably do it, but as you can look at the MRSA, like it's methicillin resistant, right? So Naftalin is going to be 0, right? Naftalin is pretty much like methicillin. So you might want to look at something else other than Naftalin. Go to the green one, so tobramycin, gentamicin, but it's not going to be your first line for MRSA, right? So look at linezolid. It's too broad, daptomycin too broad, so vancomycin probably going to be your best bet for first line. You have other stuff too that you can use for MRSA. But again, this is just a guide to kind of tell you what they are susceptible to, but you still have to make decision in terms of which antibiotic would be the best first line for the patient. Same thing with the gram-negative. It will kind of listed all the gram-negative bacteria here with the susceptibilities for each of the antibiotics. And the difference between that is this is the gram-negative E. coli and urine species specifically. The other ones are combinations of blood, urine, for the other bacteria as well. So just kind of because E. coli is very common in UTI, right, or in urine. So that's why they have a more specific specimens susceptibility report. Candida, if you ever look at, have somebody who have fungal infection, then again, similarly, you will have different Candida species with different susceptibility for different antifungal. And last tab is antibiotic restrictions. So every single hospital, they have restricted antibiotics where there needs to be a specific criteria why you're using it. One of the reasons why we restrict this antibiotics because they're very broad. There is other alternatives that we can use to treat infection first before we go to this antibiotics. So there's should be criteria. A lot of times it's going to be like either like they have a true allergies, anaphylaxis, urticaria, shock to penicillin or cephalosporin, so that you pretty much, delete all the antibiotics they can use, like penicillin and cephalosporin, or like they have multi-drug resistance, right, that might not might not be susceptible to cephalosporin or penicillin, you can go to aztreonam. Fluoroquinolones as well, if they're not susceptible to cephalosporin or penicillin, some medications, or if they're have allergy to beta-lactam antibiotics, then you can do fluoroquinolones as an option. Carbapenem is very broad antibiotic, so we don't typically use it until they are very, very resistant. Same with this too. These are newer cephalosporin medications, very expensive. So we don't really use it until if they are resistant even to like carbapenem. So very, very rarely you will see this until they're very resistant, very severe infection. Linezolid, diptomycin, typically use vancomycin first for MRSA, unless they're resistant to vancomycin, or vancomycin resistant enterococcus, then we might use either of those. Ceftaroline as well, can cover MRSA, but we don't typically use it until we exhaust vancomycin, linezolid, diptomycin. Tigecycline, very, very broad, can cover a lot of gram-negative, gram-positive, Pseudomonas, MRSA. So we don't typically use it until like they're very, very resistant to all the things above even, right? And fidaxomicin is for C. diff specifically only. And again, it's not going to be your first line if you look at the guidelines, right? It's going to be, later lines if somebody failed vancomycin, metronidazole with C. diff infections. And that's pretty much it for the antibiogram overview.